Okay, we have time for questions, comments. Cards up will be easiest. Yes.
Fran Henry, I'm a forum member, and I have a question each for Dr. Wolke and Dr. Pardini. Dr. Pardini, I didn't appreciate very much each of your presentations. In your presentation, I didn't, unless I missed something, I didn't quite understand the analysis of youth violence from a mental health perspective. It sounded more like you were analyzing youth violence within a social conduct disorder framework. And I just wondered if you would comment on that from a mental, how do you see your work within this mental health, mental illness framework? And it just may be me missing it. So, and then Dr. Wolke, I am wondering in your work whether you have investigated bullying within the family, that is bullying by parents might be considered in that case emotional abuse, but or maybe more importantly for the work that you've done, among siblings, because certainly, and would you from the work that you've done, would you comment at all, within the family situation?
So from a mental health perspective, if you consider oppositional defiant disorder and conduct disorder as mental health disorders, those would be the factors that are the main driving predictors of violent behavior in adolescence. When you look at factors such as internalizing disorders, depression, anxiety, and even ADHD, you really don't get a strong relationship between those early mental health conditions and adolescent violence. That's not to say that it's not a contributing factor later on, but when you look at the precursors, we do take those mental health conditions into account, and they are not robust identifiers of what kids will go on to exhibit severe and chronic violent behavior.
Answer to your question, it is very important that I find it quite fascinating because I started as a psychologist to study parent-child relationships. And it became over time clearer. By the time you're 18, you have spent much more time with peers than you will have ever spent with your parents. And you want to be accepted by your peers, like you want to dress like your peers, you like the music, you don't dress like your parents or the music, etc., and so on. So peer evaluation is extremely important. And Michael Rutter wrote a long time ago, something 15,000 hours, the impact of just being in secondary school. So when we started looking at this at parents, because we controlled for parenting behavior, one of the things that became very clear that most of the abuse, a recent NSPCC review, which is the National Society for Protection of Children, showed that the most violence you ever experience is by peers and siblings. So now you come to the siblings, and we have looked at sibling bullying. And it's very, very frequent, fights between siblings. In fact, so many get actually to A&E, but never admit that it was a sibling who hit them over the head, etc. And what I found fascinating is that implicitly we have got an idea, if someone would push you, pull you, and throw you off a table or hit you around the head, if it would be a stranger, we would phone the police. If it's a peer, we go to the school. If it happens at home, you often say, come on, stop that. And the question is now, the behavior is exactly the same. Does it have the same effect? And we are now looking, and we have looked longitudinally at sibling bullying, and it also has got adverse effects. But in particular, it combines with peer bullying. The interesting thing is that the home is a breeding ground. I mean, sibling violence is a breeding ground whether you're more likely to become a bully in school or become a victim. Those who are more frequently victimized in their own home by a sibling are 4 times to 12 times more likely to be a victim at school as well. And those who bully, we are just reporting that, are 3 times more likely to be bullied outside as well. So if you think about intervention, you should start very early on in sibling relationships to actually not let them go and become violent or become very difficult, but actually to have the strength to moderate them. The second thing is important. If you're victimized at home and you're victimized at school, there is no safe place for you. And we found you're 12 times more likely to develop a mental health problems because there is just no respite. You come home from school, the same thing happens again. So it's a very important thing to look at both family and the peer relationship.
Peggy, then Mark, then Fran.
I just wanted to, I don't know how, but in one of the presentations, there was a sort of the use of the term diagnostic, and screening is not diagnosis, and I think we have to make sure that we keep those separate. Screening is also not assessment. I'm glad, Dr. Pardini, that you brought up the harms of false positives, because even in something as innocuous as blood pressure screens, a positive blood pressure screen has been shown to decrease productivity, increase illness, just from the thought that you might have high blood pressure. So in this area, I think it's 10 times or even more, maybe 100-fold more important to be very careful about false positives. And my issue, again, as I brought up this morning with Dr. Insel's talk, in screening in schools, we know that information is not safe. That's why we don't promote drug and alcohol screenings in schools, A, because, you know, what do you do with a positive screen? And B, the negative impact on that individual's life is really, and in drug and alcohol screens are protected in the medical record. They're not, and so I don't know if something like this is even protected. We have laws in place in the United States to protect information on screening and diagnosis for alcohol and drug problems, but do we have anything that would protect an individual from being screened positive for? So I'm just saying that this opens up another whole area that we have to consider in terms of the false positives. And while yes, there's certainly a lot of value in being able to screen, usually it's in more in a population level. But at the individual level, so much can happen with false positives that I think we have to sort of make sure we have safeguards in place and be very careful of who does the screening, where the information goes after that, and you know, what happens to the individual.
Mark.
Again, my thanks to everyone on the panel. Despite having good excuses for poor performance from being jet lagged or traveling too far, you did a wonderful job. So thanks to you all. And Dustin, you seem wide awake, more wide awake than some of the audience.
But you don't know it.
I wanted to make a couple of points about bullying. One, Dieter, when you showed the slide of the headlines with children who've been bullied and committed suicide, this is an area rife with difficulties. When a child commits suicide, when anyone commits suicide, Michael told me this last year, the first and universal response is feeling guilty. Oh my God, I let this happen. Why didn't I see it? Why didn't I intervene? And when it's your child, it's much worse. And there is a tendency that we see very commonly in this country in the press that the parents first blame bullying and blame the school. It's a routine. They talk to a lawyer, they go on TV, they're in the papers. The newspapers show the story how terrible the bullying was and how it led to suicide. And then later, 6 to 12 months later, there's a much smaller article in the paper that says the charges against the school were dropped because there were many more complications at home. And frequently these children turned out to have been seriously abused and victimized, not by a sibling at home, but by parents. And there's serious mental illness and chronic depression. The stories turn out to be much more complex and complicated, but bullying is a diversionary tactic. And I just think we need to be very careful about that because of the way it's used and misused. The second thing is just a general caution that it's very hard to show causality. And in the area of bullying, there are many associations that we can't show are causal associations. And it's just very, very important, I think, as we go to separate the associations from ways that we can show causality. Causality has been shown very rare in the area of bullying, but there are many things that are associated. But again, it's one of these very complex issues and very complex areas. So just a word of caution to us in general for how we interpret those results.
Could I answer to that? Well, the first question, I put up the newspaper clippings because exactly for that caution. But we had the possibility to investigate this in a longitudinal study. Now, unfortunately, and rightly so for ethical reasons, you can never do a treatment study on bullying. So you can't randomize children to be bullied or not. So the best data you will ever get is observation data. And I think this study was particularly good because it started in pregnancy. So we could even look at pregnancy effects, whether it was drinking during pregnancy, mental health problems of the mother, even before the child was born, because it could also be a reaction to the child. And we could pattern them over time, and we controlled for diagnosis, DSM diagnosis at 7 years of age, to look at 12 and at 17 years of age at self-harm. We controlled whether they had depression, anxiety, family relationships, community problems, etc. And still, this strong relationship of bullying came out. The second thing is for causality, if you look at it, is that you try to go through a number of different criteria. Like, for example, do you have a dose-response relationship? That suggests closer to causality than not. And we actually have demonstrated the more chronic the bullying is, the stronger the effect is. So we can never 100% say this is causality for the reason that it will always be an observation study, but we have got precursors and we can look over time. And I think with 20 years of research now, with different studies and just reproducing it, I'm much more certain that there really is a pretty strong relationship, a stronger relationship than we ever expected.
Fran.
I would like to ask Dr. Pardini, when you talked about your risk factors, I noticed that you had a whole list of things, but one thing that I saw was missing, or maybe I didn't see it, was the adverse childhood experience, trauma experience as a causative factor. Was that not included in any of your assessment things?
Yeah, I couldn't put up all of we had like 52 different predictors in that study. That study aggregated across all three cohorts. So we had information from 7 years old to kids that were 14. We had information on the level of physical punishment in the home, and also information on official records of physical abuse and neglect. Those factors were related to future violence, but when you added them into a regression equation to see did they incrementally predict above and beyond the other risk factors, it didn't come out as significant. Now, if we just selected the younger kids and looked at that kind of trauma or abuse just at a very early age, it may have, and that's kind of what we want to do next, is really get more specific developmentally about where we're measuring these things.
Sheldon.
Sheldon Greenberg with Johns Hopkins University. Coming back to the bullying, and I'm particularly concerned about the bullying of young people who have mental illness. It seems to me that, and I ask you to respond to this because of your own definition, your definition of bullying includes hitting, kicking, pushing, threatening, and stealing. And then you gave the example of the young child being hit in the head and pulled off the table. Those are crimes. That's not bullying. They're criminal offenses that, based on the one you described, rise to aggravated assault and felony. Aren't we failing to deal with the problem because we're masking, in this definition of bullying, criminal offenses that could be addressed in the school as such if we change the core definition?
Let me just answer to that. The interesting thing is there are actually two studies from the United States, from crime surveys, that you hardly ever, even though they have been reported, like, for example, felonies, that parents take their children to the police and saying a felony has been committed. It actually nearly goes, within families at least, with sibling bullying, gets undetected. It's very rare when it becomes so dangerous that they do this. So that's one of the things. A lot of bullying in school actually occurs in places like in the playground, on the way to the playground, but also in the school if the teacher is out for a while. and so on. And it's quite amazing how violent some of this can be. But don't misunderstand me, the psychological exclusion we found has got as bad effects than the scars. Because there's psychological scars like being excluded, systematically being excluded, not being part of the group, then having messages sent, being ridiculed on the internet, on Facebook, and so on. All of these things together give as many scars, I mean, for mental health problems. Now, exactly the law in Britain, they were thinking one was the Aden law, because a child killed himself and the parents were campaigning for it, and they had some of the members of parliament on the side, to actually make it a criminal offense for bullies. I think that most of the evidence, for example, from Scandinavian countries shows, and as you know in the United States, the highest incarceration rate has not led to less crime in this country, is not very effective. There is very little effectiveness of criminalizing people. It is actually much more effective to rehabilitate them and find positive ways and new role models for people rather than criminalize it. And I'm very pleased to say that it will not become law. It should be more giving help to bullies, but in particular to the victims, to actually have special needs and help them to do right. But that you have got very clear rules in school which are not criminalizing them, but very clear rules of what is acceptable behavior and unacceptable behavior. It's something different than making it a criminal offense.
Oh, okay, Eric?
I want to bring up results of a study very quickly to sort of throw this into some perspective. So colleagues and I in Taiwan looked at about 175, 180 men who'd been admitted for acute alcohol detoxification in Taiwan and asked what were the predictors, what factors in them would predict having made a lifetime suicide attempt. Wasn't depression, wasn't current suicide ideation. It was a combination of 4 or more childhood adversities plus having already perpetrated some type of interpersonal violence. And so one of the questions that I have and a problem I have with bullying in isolation is that while it may be powerful, it also may be a surrogate for a variety of other childhood adversities, picking up what Francis was saying. And the question of how this all then arrays with things such as drinking and interpersonal violence, I think are things that we need to look at. And so the detection, trying to do, how should I say, a single lead detection factor may be inadequate for the very reasons that we've heard today, but also because the picture is much more complex.
Answer to that. I mean, of course, we have looked at, well, we have of course looked from prenatal factors at parenting behavior. We have a meta-analysis on child abuse published last year. There is a relationship of this. In our studies was very important that the balance at the moment is still, which is very interesting when you look at it, is on parenting per se. But you actually make a lot of adverse experiences with peers. And one of the most notable things is when you go to mental health professionals, coming back to mental health, they may ask you about how you get on with your parents. They hardly ever ask you about how you get on with your peers and whether you're bullied and victimized. But it's a very important thing. I'm not saying it's in isolation. For example, victims have certain profiles. They're more likely, I mean, a bully normally has a tactic of trying everyone. If I would be a bully, you would try everyone in the room, and the one that shows a reaction starts crying, doesn't know what to do, you home in because it's easier. They don't have friends. They don't help you. So they're characteristics which you pick, but they're not necessarily mental health.
No, and I would agree with that. The other thing I would underscore is that study in Taiwan was with adults. And even as we talk today about bullying and youth, the bulk of something like suicide is in adults. And there already is accumulating literature that early childhood adversity, being a victim of bullying and other things, ramifies all through life such that by the time someone's 35 or 40, and I'll use he because it's more often he than she, has been sufficiently scarred that they're very vulnerable to social losses and other things at that age. So I really think it's very important to put this discussion in a larger context than youth alone.
Michael?
I have a couple comments. First, about criminalization. It's the same true in suicide. Suicide is criminalized in many countries, and it definitely does not help the prevention of suicide at all. In fact, there's a strong movement by the International Association to try and decriminalize it in the many countries that it is. Another concern I have, if we eradicate bullying, does that mean the current bullies are going to have more mental illness? It looks like it from your graphs that, you know, they have less mental illness than the norms. So if you eradicate it, then what's going to happen to them? So what's the downside? You know, what's the unintended consequences? Right, the elevated, so what are they not going to get, and how can you replace that for these kids who need the bullying to sort of support their psychological health? Another issue that raised, thinking of China, where most urban centers still have only one child per family. Do you have comparison between kids who are single children versus have SIBs? And is there really, you know, if the SIB is sort of where the sibling rivalry, sibling bullying is what starts the process going in settings where there's no SIBs, urban China, for example, is there a lot less bullying generally? Or, you know, there's other factors there, but you could, at least in your own studies, compare the households in which kids have no SIBs and those who do have SIBs, balance other things out, see what the, you know, what are the long-term concerns and outcomes. In terms of predicting, bullying or and the prediction measures that you talked about, it relates to what Tom Insel said this morning. A lot of the measures, for example, looking at the predictive power of mental illness, the real question is, are they being treated or not? And it sounds like most of the studies that look at the relationship between mental illness and some of these outcomes don't divide those up. And that seems to be, for example, the ECA study that looked at the prediction of the relationship of mental illness to violence. They just, did you have a mental illness and at any time, and was there violence? There was no relationship between the violence and was the mental illness being treated. That clearly is the really, it appears to be the determining factor. And most of the studies that looked at predictive instruments kind of predict risk. Is a person mental illness with treatment worth not? So we're dividing those to see what is most predictive. Is the instrument predictive in a person who has a mental illness who's not being treated versus a person with mental illness who is being treated? Similarly, the concurrence of mental illness and alcohol abuse. You know, the combination of those seem to be what is the real predictor. And so when you look at the relationship between the ability of instruments to predict violence, and we look at mental illness, one to look, is they're being treated? Do they have comorbid alcohol abuse? Because those are really the things that maximize the potential of mental illness. And it doesn't sound like most of the studies have divided up those ways. Similar to this morning, we talked about the difference between follow-up studies following hospitalization and the community studies. Following hospitalization, the risk of violence in the mentally went way down. Well, those people just been treated, so the rates were lower, whereas those who were done in the community, a lot of those people weren't being treated. And the community studies didn't divide up those who were treated and those who weren't treated when they looked at violence. And so clearly that's a parameter, a variable that we really need to include. One, treatment or not, and two, comorbid alcohol, particular alcohol abuse or drug abuse, to look at, find out if these things really can be predictive.
There are a couple of people in the audience. If you could go to the mics, then I can make sure to call on you. Oh, okay. Oh, sure. Go ahead.
Just a general comment, which relates to some of the points raised so far, is that I think one of the key things is to look at the incremental predictive validity of risk factors. So, I mean, and cardiovascular medicine has sort of pioneered this, you know, because CRP is related to cardiovascular outcomes, but actually doesn't add anything to age, BMI, and I think cholesterol levels. So you can find lots of associations issues, whether they actually add to predictive ability. So, I mean, as far as I can tell, in mental health, people haven't really done this approach. It hasn't really filtered in or translated into this area. In relation to the instruments, some of them do look at treatment. I mean, they look at it particularly in terms of adherence. And it's actually a very powerful risk factor. They pretty much all do also include comorbid substance abuse, which, as you say, is a very important risk factor.
When you look at the area under the curve
Yeah.
and the positive predictive value, you
Yeah.
don't divide out those factors, and that clearly will be very different for those subgroups.
Absolutely. And I mean, I think that's partly what I was getting at about diagnostic specific. I think I was trying to say that there may well be subgroups where you can improve these AUC values because you have stronger associations which are measurable and add to the incremental predictability. I mean, there's interesting enough that there was a study done by a methodologist, John Ionides, I don't know how to say his name, he's at Stanford, and he took the a cookbook in Boston, where I think he was living for a period of time, and he took the 50 ingredients in this cookbook, the 50 most common ingredients, and every single one of them was associated with cancer. And I think his point was that you know, individual factors, you know, it's quite complicated. It's probably what Eric Kane was saying just now, is that actually the best evidence is probably something to do with the Mediterranean diet that reduces cancer risk. But looking at individual factors is very difficult because, of course, they all interrelate and they're all to do with lifestyle factors. And you don't just eat, you know, cumin by itself. You eat it with, you know, Coca-Cola and coffee and everything else that might interact. So, so his argument was you need to throw everything into the pot in a way and look at diet rather than just and I think this relates to how to develop these instruments and improve maybe the quality of the instruments is have a broad set of risk factors and think very carefully about incremental predictive validity beyond things like gender, age, really basic things, comorbid substance abuse, treatment. You know, is there anything can add to these factors, which are pretty straightforward in terms of extracting them from individuals.
Okay, I think someone has the mic. Could you stand up?
Thank you. Anyway, I'm Shep Kellum from Johns Hopkins School of Public Health, Department of Mental Health for many, many, many years. And before that, I was running a neighborhood mental health center, one of the community mental health centers, south side of Chicago.
I just need you to put the mic, yeah.
Oh, the mic.
Thanks.
I'll try to not let my arm wander. Good. But I was intrigued by Dr. Pardini's presentation because we invented the TOCA 35, 40 years ago. And it came out of a community board which oversaw what we were doing in Woodlawn. And since then, it's been used in multiple, many studies. What I'm impressed with is the need for a theoretical background which explains what the heck the TOCA was all about, or the theoretical background which explains many of the things we've been talking about, including bullying. Aside on that, the Miami Dolphins at the National Football League have a roaring argument and a huge problem with bullying among the offensive linemen. And there was a guy being hauled up, and there was suicide as a potential danger by the bullied lineman who was getting, these guys are getting, you know, millions of bucks a year. So it's an important issue. But getting back to the TOCA, it came out of a theoretical framework that said that there's stages of life, having Hearst or whoever you like. At each stage of life, people are involved in certain major social fields. Classroom being one, family prior and continuing, peer group, evolving from earlier classroom experiences and so on. But Bob Cairns used to study the continuity of peer groups over time. So we did an intervention deliberately chosen because it addressed the social structure of the classroom. Left to their own devices, first grade classrooms divide up into tough groups and succeeding groups. So we ran randomized field trials up the kazoo, thousands of kids, many schools, and over the years. And it turns out that, in fact, this malleability, the malleability of kids with early aggression was pretty impressive. And if you didn't do anything, they led to prison. The article that you mentioned, Hanno Petras led, and but it also led to reduced, the intervention led to reduced high-risk sex behavior, which otherwise was high among this group. But it only related to those kids who had an earlier history and a lot of continuity with aggressive disruptive behavior. Those kids had a fairly stable long-term impact outcome, but it was malleable. And it was malleable by manipulating, by bringing the kids into teams and rewarding the teams. They were mixed for behavior and mixed for for gender, half boys, half girls, and those teams took over, replaced other classrooms, controlled classrooms, in which the kids are left to their own devices, form their own groups. So I merely want to say that the theoretical framework is we're talking about the social adaptation of kids to over course of stages of life and how that can be an influence on the behavior, but it may be malleable. And it turns out there was in the Petras article, we found a reduction in prison, a reduction in drug abuse disorders, reductions in other outcomes that are all outcomes of this early risk factor. By the way, the early risk factor is the most established of the risk factors that among the most that we know about. Early aggressive disruptive behavior is a bad idea. It's always associated with attention issues for the most part. So anyway, I wanted to give you some framework of all this. Anybody's interested in all this, I left a couple of special issue we did for drug and alcohol dependence a while back. Hendricks has been involved in my compatriot for all these years, and along with a bunch of other guys. So I really enjoyed hearing about the modern uses of TOCA as part of Fast Track and other, and I could send you stuff we could exchange because I enjoy hearing what you're doing.
I'm really glad that you're here. I think what's interesting is that this measure was developed years and years and years ago, and it was never really intended to accurately classify kids, and we're still using it today. And we know that from developmental models that there are these factors that are believed to be driving conduct problems and chronic conduct problems, family factors, peer factors, all of these host of other things. But we're not assessing those in these current studies, looking at who should be getting these services, who are the kids most at need to be going into these programs, because you do have to allocate those resources to somebody. And so what we're really aimed at is trying to augment what you've done already with this, with the well-established risk factor and adding on to it. Because programs like Fast Track actually have only been shown to be cost-effective for those kids most high at risk, because there's a lot of desistance that takes place naturally. And so if we're wasting resources essentially on kids that are going to have natural remission from these behavior problems over time, and it's trying to delineate, can we better identify the group that we should be targeting?
Thank you. Let's give our panelists a round of applause. Thank you all, and I should turn it back over to Peggy.
Yeah, we're getting ready for a 15-minute break just now, but I do want to remind people that the reason we're being so particular about the microphones is that because this is webcast, and I just got an email from a colleague. It's important to speak into the mic and to try to keep it sort of even, so that they can understand the questions and the answers. Because like I said, my colleague who's trying to watch this on webcast said he could hear some fluctuation and he can't hear all the comments. So that's just why we're being so particular about that. Thanks. Thank you, panel, for